Hello, everybody. Welcome to another dialogue talking about a variety of issues, an expanding list of issues. We're going to kind of tread water here for a few minutes while people come in from the waiting room, and we're going to hopefully give you a chance to think of your questions as we go along, put them in the Q&A, and we'll get to as many as we possibly can. It's always it's interesting to see who's here and the questions you have. I think we can go ahead and start. This is an ongoing series of dialogues that is sponsored by the International Antiviral Society USA. We think of IAS-USA as being all about HIV, which is how it started. But the organization has broadened to encompass other chronic viral infections, and more recently, obviously, to address COVID. The latest kid on the block is monkeypox. We're going to hopefully talk about that a little bit later in the program, and I think there, as we go along, we can expect to see other viral infections emerging. It seems to be an important thing. So with us today, we have several people that those that have been here before will easily recognize. On my screen from the top is Peter Chin Hong from UCSF, Bonnie Maldonado from Stanford, and Mike Saag from UAB. We often have Carlos Del Rio, but Mike and Carlos are a great tag team. Carlos is in the other Georgia this week, he says, the country of Georgia. And so rather than forcing him to join us at 3 a.m., Mike has agreed to come in again. And I think you'll agree that all three of our discussants are incredible experts in the area that we're going to try to address today. So as I was saying, as we started, we'll watch the Q&A function. The Q&A function is where we'll look for questions that you might have as we go along. And again, we'll try to address as many of your questions as we can. We have a lot of people signed up today. 450 are signed up so far. About 160 are with us already. So that's great. And so welcome. Maybe let's go through our discussions and introduce yourselves. Tell us a little bit about you. Just a couple sentences. Maybe again starting with Peter.
Hello, everybody. My name is Peter Chin Hong. I'm an infectious disease doctor, professor of medicine at UCSF. And during COVID, did a lot of communication, ran trials through our group for UCSF for all the major antivirals and anti-inflammatory meds. And I'm getting increasingly involved in monkeypox therapeutics as well.
Great. Mike, you want to go next?
Sure. I'm Mike Saag. I'm at the University of Alabama at Birmingham. Was an unwitting pioneer in COVID. I got infected in early March 2020 and learned the hard way what this was about. But then since that time, I've been involved in patient care and also communications about COVID, and especially focused a little bit on long COVID.
Great. And I notice that we have some great friends, Kevin Carmichael, who's a great supporter of the organization, and Janet Silicano from Hopkins and others. I'll kind of try to call out people as we go along. Bonnie, introduce yourself.
Hi, I'm Bonnie Maldonado, and I'm a professor of global health and infectious diseases at Stanford. I'm a pediatric infectious disease epidemiologist, primarily working on vaccine preventable diseases in kids, primarily in developing settings. Did a lot of work with PMTCT, HIV prevention from mother to child in sub-Saharan Africa, and like the others, became a COVID expert, although as far as I know, I haven't gotten infected yet, but that may just because I missed was asymptomatic, I have no idea. But I did start off early on with large scale Bay Area wide epi trials with my colleagues at UCSF, as well as doing antiviral studies here at Stanford in the outpatient setting, and more recently working on pediatric vaccines. So a lot of work among the three of us here so far.
And that's great. And we will definitely get into pediatric vaccines. I know that the last time we had this dialogue, there was a lot of interest because things were still very much in flux. I think it's still fair to say that things aren't quite fully settled yet. Mike, why don't you start by just telling us what's happening in the last few weeks? What are you watching with this, and we can begin the conversation.
Yeah, I'd say it's variants. So just 6 weeks ago, we didn't see much BA.4 or BA.5, and we saw cases South Africa and some other European areas, but now the US is really getting hit hard with BA.4 and now BA.5. It's causing a spike in cases. Second thing I think we're seeing is that while it's hard to judge exactly how many cases are because so much use of home testing, so we can't track the numbers of cases other than what's in the hospital and of course those that show up for testing at hospitals. But it really feels like we're in the middle of a surge right now. Fortunately, the majority of people are not getting critically ill. The usual risk groups are getting sick. But I think I can't tell if that's because these newer variants are less virulent, and we can talk about that, or whether there's been so many people who've been vaccinated and boosted, and also perhaps on top of that had an infection, often with Omicron early on in January, that we're not seeing as much illness. But I can tell you, I think for anybody who's a provider right now, your phone's ringing off the hook, your texts going crazy, and sometimes often not even patients you take care of. It's friends, relatives, friends of friends, and it's becoming a little bit overwhelming. I don't know what you guys are seeing.
Well, one of the, it reminds me to add that Carlos Del Rio, who is often on this call himself, has just been recovering from COVID, and unlike a lot of the people that we've heard about, he was quite sick, not sick enough to be hospitalized, but really quite symptomatic. So I think one of the things we want to talk about is kind of what are we seeing in terms of the illness that's happening as COVID is the 4 and 5 variants the same?
So the study just came out. Yeah, just after we spoke yesterday, I was reading an article looking at healthcare workers in Italy. You may have seen this, Peter and Mike, but it was a prospective study of healthcare workers that were followed for almost 2 years with weekly testing. And what they found was they went through several waves, but they found that vaccinated healthcare workers were significantly less likely to get infected. Unfortunately, they didn't seem to find any difference in symptoms, but they definitely found that people were less likely to get infected. And this was through the Omicron period as well. So I think they've got some good data there. But what you said, Mike, is probably right, that it's all of the above. I think we're heading into an endemic phase at some point. I don't know when we can officially say that, but there's plenty of immunity from vaccine, from infection. And I do think that these variants are also probably less virulent. So it's probably a combination of all those.
Yeah, so I agree with that too. I think in terms of the protection of vaccine in the Omicron era, it's still actually protective, just not as protective. Riffing off Bonnie's study of the Italian healthcare workers, I think to me, last week's CDC report which focused mainly on mortality difference, 14 times more if you're unvaccinated and 4 times more if you've gotten one booster instead of 2 for over 50. But if you look at the infection curves, unvaccinated versus vaccinated, still much less infection, even though it seems everybody's getting it. It's not necessarily true. Like Bonnie, luckily I haven't gotten it as yet. But again, I'm not fearful of it, and I'm just trying to do the best I can.
What are you seeing, in any of you, in terms of what you observe in your, as you go around your communities, in terms of what people are thinking? Are people kind of paying attention to this? Are people masking? What's your sense of the mood, Mike?
I'd say it's forgotten but not gone is probably the best way I'd describe it. And I'm going to go to this event this evening in Birmingham in a large crowded space. I bet I'm one of 10 people out of 40,000 who might be wearing a mask.
Yeah, right, exactly.
I just got back from a long weekend in another state, and but I guess it doesn't really matter. So because the airplane, most people were wearing masks, which was interesting. Going out there, coming back as well, but in the crowds, very little. I would say we didn't really go indoors very much, though. But I think it's interesting to, well, a lot of us saw Eric Topol's commentary and then his New York Times quote, and people are getting infected, but I think they've just, at least here, I was mentioning to Paul and Peter the other day that the Stanford students have just decided, I think this is true among campus students or overall, they're just going to get it and get over it because they don't think they're at high risk because they're all vaccinated. And to a large extent, that is true. But we did also see last week data from CDC that the first time I've seen them put together a comprehensive list of long COVID, and it's not insignificant. So it's a reasonably high number of people, in some studies as high as a quarter of people with longer term symptoms. Now, what that means, hard to say, but I think people in the real world are just, they're worried about gas prices and inflation right now, and I don't think COVID is on the list anymore.
So let's dig into the long COVID now that you've raised it, Bonnie. Obviously, that's what I think most people are most afraid of in this. What do we know? How come we don't know more? It feels to me as though it's still pretty vague. We hear reports all over the place. Does vaccine have an effect on long COVID incidence or severity? What about prior infection? Who wants to start that? I know that everyone's got some thoughts about that.
Why don't you start, Mike? You have that background.
Yeah, so I think there's a couple things. The actual incidence, if you will, of long COVID isn't fully worked out, so there's a range, but I'd say it's at least 3%. And it can be as high as 10 to 15% in some studies, but it's devastating to a lot of people. Remember that it can affect major organ systems, and it usually is one or the other: brain, lung, heart, gut. Those are the most common. And the brain can be divided into issues with long-term loss of smell. I've seen some things with hearing, chronic headaches, and then brain fog. And there are people who really are suffering with this. We can all think of people who have had, there's a guy who had to retire as a vet because he couldn't think, and it's been over a year. The news that I'm hearing this week, in the last couple of weeks, there's a study that showed, to your question about vaccination, that those who are unvaccinated have a much higher likelihood of long COVID. And if you've had at least two, and the more, especially of one booster or more, the incidence drops dramatically. So vaccines seem to help in terms of prevention. And there were those intriguing studies a while back that showed that a few people, not a large number, but some who got vaccinated found that their symptoms abated. Going out on a limb here, and I'd like to hear what other people think about this, to me, what it seems like is going on is that the immune system gets hijacked by the virus, and the normal stand down orders are not heeded. So normally you get infection, you have symptoms caused by immune system reaction, and then when the pathogen's taken care of, everything just sort of abates, you go back to normal, relatively speaking. Somehow or another, there's parts of the immune system that just don't get the order or don't heed it, and there's continuing inflammation. At least that's my working thought. The problem is that steroids and other things don't seem to work, so it sounds more complicated.
So
I think that's right, Mike. I think one of the things that we're seeing here is Michelle Monge, who's one of our basic science neuroscientists, has looked at some of the inflammatory effects on the brain. And she says that their research has demonstrated that it's very similar in the response that you see to chemotherapy. So it does look like there's some longer term neuroinflammatory impacts that we don't really understand. Maybe some of it may be cytokine related. Some may be other kinds of inflammatory pathways that we're not quite sure. And you're right, it's dysregulation. And the other one I wanted to bring up, Paul, is just the fact that we still don't know what happened with those hepatitis cases in kids. But some people have suggested, now the numbers fortunately flattened out, but that there may be some relationship between an abnormal response, for example, to normal viral infections in people who have previously had COVID.
Yeah, I want to get back to the hepatitis in kids a little bit later, Bonnie, and hope you can help us there, because it seems to me as though it's getting more confusing, that it's not quite as clear, not that it ever was. But how much do you think this is like other post-infectious problems? I mean, we see, people with Lyme disease that have had chronic Lyme disease. I know it's been controversial. Chronic fatigue syndrome is, I think, often thought to be a post-infectious problem of some sort. Are we seeing something different with this, or is this just yet another one of these post-infectious problems? Peter, do you want to toss that around a little bit?
Yes, I mean, even before COVID in ID clinic, and I'm sure seen by many other people in the audience, I would see people who had chronic post-viral symptoms that lasted for sometimes more than a year. They came to us because they wanted to make sure they didn't have residual virus, but they were really debilitating, and we never really had a good explanation for it, whether or not it's CFS or they were diagnosed with all these different things. Some scenarios that I've seen personally were people with Giardia, for example. They got it a Peace Corps volunteer, and then they continued to have these chronic symptoms that lasted for a long time, and then viral syndromes too as well. So it's not new. We've seen it before with influenza. It's well described, but I think the scope of infection of COVID, so many people, and also COVID is probably SARS-CoV-2 is higher, has a higher likelihood of causing these symptoms for whatever reason, results in the scope of the problem. And even if we say, sure, it's 10 to 20% of people overall, but even if you say 5% will have symptoms that are debilitating that last more than a year, that's 5 million out of 100 million people in the US. It's like breathtaking. Like it's really going to be something we have to deal with as a society for decades and decades.
So one thing that's actually, and I agree with all of that, but one of the things that I think is different here. So in pediatrics, we also deal with a lot of ADEM, so acute disseminated encephalomyelitis, not with COVID, interestingly enough, but with other post-viral illnesses, we never make the diagnosis of the virus, but it's following a clinical viral illness. But what's interesting here is we're seeing a really interesting mix of direct organ damage. So for example, cardiac disease, we've heard a lot about the cardiac dysrhythmias, pulmonary disease. So it's direct viral influence. But then you have something that I really haven't seen much of. I'm getting a number of referrals here. We have a long COVID clinic as well, as you probably do. But neuropsychiatric disease. So some of this occurs in people who have never had neurologic disease, but short fiber disease, which has really been very interesting coming in particular, at least in my case, from what I've seen. And I've only heard of this happening in young adult males. Now, it doesn't mean that's the only group. That's where I'm hearing it from, but we haven't seen that as much in young children, but in young, 20 and 30-year-olds who had COVID early on before vaccines were available. Some of these were healthcare workers, but some were not. And so you see that, and then you see the psychiatric manifestations, which also have been very distinct. Some people with a predisposing psychiatric issues, others not. So just a real hodgepodge of responses.
So there are a couple questions that are coming up in the Q&A that I want to help guide us here. And broad issues of vaccine effectiveness and Paxlovid related issues. So let's start with the vaccine. So Mike, you were saying that we're seeing obviously more BA.4, BA.5 in the United States. What do we know about vaccine efficacy? What do we hear about plans for changing the vaccine? And what do we recommend to people now that are thinking about whether to get their next booster?
Yeah, so complicated, right? So
yeah.
I think the bottom line is that I think there's no question that the vaccines still protect against advanced disease, hospitalization, ICU visits, death, no question. Boosting is important, especially for older people and people at higher risk. All that said, the variants are still largely unknown. And I think just an editorial comment real quick, we got to remember we're only about 2 years and 5 months into this. Yeah. I mean, what we're used to
seems much longer.
What we're used to in medicine is decades worth of experience, and we don't have that. We don't have that luxury. What we do have is an amazing amount of technology and understanding and scientific know-how that we are applying in ways that are truly miraculous. So in that regard, I think the thing to watch for in October are these either monovalent or bivalent vaccines coming from a number of the manufacturers, Pfizer, Moderna, others, that will be BA.4 or BA.5 plus the original. And I think that's the thing in October to look for. So timing, if you're not at a high risk group, you may want to, slow walk your next booster till that time. People that are at high risk need their 6-month booster, probably get it now and then look to November, December for the booster. What do you think?
I think that's absolutely right, because we know that Omicron responses, even to the ancestral strain in the vaccine, are not very long-lived in terms of antibody levels. Now, they are protective against serious disease, but if you're at high risk, you probably want to get a booster now and expect a booster in the fall with the variants. The BA.4 and BA.5 spike protein sequences are identical, or pretty close to identical. So the BA.4 and 5 non-spike protein pieces are different. So you will get some cross protection, but whether they're 5 or 4 or both, they work well so far, at least if you look at animal models and neutralizing antibody. The data, as you heard from Mike, are very few, but the interesting thing is it does appear that having the ancestral strain mixed in there does seem to boost the response overall. And by the way, as you said, Mike, we haven't been in this very long, but these vaccines have worked pretty darn well considering how much variability there is to this virus.
Great. Peter's thoughts here?
Yeah, I agree with everyone. I mean, I thought it was interesting that when Pfizer and Moderna had banked on using BA.1 and the original cocktail, had started manufacturing it, thinking the government would buy it. Then they released the data and showed it was only like 1.5 times more antibodies against BA.4 and 5. So the FDA said, hey, wait a minute, BA.1 is old news. Why don't you include BA.4 and 5? Otherwise, we would have had something at the end of summer. But because there's going to be a delay, it's going to be October and November. But I agree with everybody that even if BA.4 and 5 aren't there, and maybe we have BA.6 and 7 or Pi or Rho Sigma, it's
Right.
still going to be updated, and hopefully will increase infection prevention. But I'm really psyched so far with the effect at preventing hospitalizations and deaths. So that is a big success.
So there's a question in the Q&A that's a very practical one and close to my heart. Healthcare workers over 50 years of age had their 4th vaccine, but it's been, let's say, 6 months. Go for a 5th? Is there any reason not to do that? Did you wait until the expected new version comes out in the fall? What's your advice to people?
Now,
Bonnie?
I think it depends on if you're in a healthcare setting, you're by definition in a high risk setting. So I would say if you think you're in, in an academic or tertiary hospital where the flow is really high, that might be not a bad idea. And really, I don't think those people are at high risk for getting hospitalized or dying, but do you really want to be out of work for that long? Because we're still talking about 10 and 20-day isolation periods. So it's more, I hate to call it a nuisance, but you're going to be home and look what happened to our colleague who's not here today, not for COVID reasons, but
Right.
you get sick. It's not, I've talked to people who said, people make it sound like it's a cold. It's not a cold. And one of the things I was impressed with the patients that I was taking care of at the very beginning before we had vaccines is that they don't realize how sick they are until they put the little pulse ox on and you're seeing them desat. It's really scary. So you may be sick and not realize how sick you are until you try to walk across the room or something. So I do think that would be the reason. But
Mike is smiling, which I think means that he wants to think
did
about.
you go through that?
No, I'll just say that sounds terrible, but true confessions, when I was in the throes of it, I'd take my pulse ox at night, it would drop to about 90 and 89. And then I'd just try different fingers until it got better.
That gotta be wrong. Yeah. It was frightening. It's, they're right on the precipice, so it doesn't take a lot.
Before there was vaccine, I had a pulse ox that I took every day just as prophylaxis, even though I was asymptomatic. So Paxlovid, let's dig into that. So great treatment, right? Prevented serious illness, prevented hospitalizations. But lately, it seems as though every time we turn around, most recently and most obviously, Tony Fauci got himself infected with COVID, took Paxlovid, and was one of many people now that have had this kind of rebound. Who wants to start talking about Paxlovid? And then I just saw a headline today in Science Magazine for next week that Paxlovid resistance may be appearing. And so let's talk first about the not the resistance, but the rebound. Who wants to talk about that? Peter, do you want to start it?
Yeah, definitely. So I think we've been hearing lots of reports of rebound. There've been some interesting new reports coming out in the literature as to what the risk is, and they could be as low as, well, the trials, it's like 1% to 2%. But there's one interesting one in CID that came out that says that in a population study was 1%, which goes counter to the popular feeling that almost everybody's having rebound, which obviously is not true. I think in my personal experience, it's probably 20% or less. But because there's so many people who are getting better with Paxlovid faster, we tend to anchor on these stories and so on. There are two flavors of people I've seen with rebound. One is that they just keep on checking and their test turns positive to negative, and then which happens very quickly in Paxlovid, maybe within a day or two, and then positive back again, but they continue to feel well. Then the second flavor, I think, is the one that makes people feel a little bit out of whack, and that is you start feeling better, and maybe you start off with a sore throat and congestion, you feel better, your test turns negative, and then you get the sore throat back again on day 3 or 4. And then you reset the clock with isolation. So I think that feeling is very disconcerting.
Day 3 or 4 after you stop the Paxlovid, right?
Yes.
Yeah, okay, good. But people, so far, have we heard anything about people becoming more symptomatic while they're taking it? I mean, the course is pretty short, so maybe that's not an issue.
It tastes bad, but it's ritonavir. But
there was a question from the audience about ritonavir. Again, with HIV infected people. Let's just quickly toss that to you. HIV, is that a risk factor for COVID infection or any worse outcomes? I think not, right?
No, it appears not to be, especially well-established patients with antiviral therapy and undetectable virus. It's really like anybody else.
So Paxlovid resistance, have we heard anything about this? Is that something that is a concern? I think
The only study that I've seen it's a very small study. It's a couple patients, and they looked at the virus. They recovered the viral isolate from people who had Rebound, and it looked the same. I mean, it was highly susceptible to Paxlovid in vitro. So, but that's just 2 patients. I don't know if Peter or Mike, if you've seen anything else, but I don't have any indication. I've seen no indication of resistance yet.
No, the thing I'm wondering out loud about sort of 2 things. One is whether those people like a Tony Fauci or probably any of the people listening right now, we're conditioned, if we get symptoms, we're testing. As soon as we test positive, boom, we're on Paxlovid within a day of onset of symptoms or less. And maybe starting that early. The studies were more like 3 to 5 days. If you start that early, you go for 5 days, maybe the duration just wasn't enough, and the virus comes back because it didn't have time to get cleared by the immune system with the sort of air support from the infantry with the Paxlovid. So that's one of the things that I wonder about. But here's a question for you guys, because I'm getting it a lot and I'm holding to the party line, but it goes to that point about retesting. And I'm telling people not to bother. Just don't do it. Follow those simple rules.
Yep.
And gosh, there's people testing like crazy and they go, I'm positive. I said, okay. And you're day 12 and you're asymptomatic, forget about it.
Right.
Yeah, I mean, the epidemiologic data, even from early on before Omicron and Delta, really demonstrate, I mean, for healthcare workers in particular, that's where we worried about it, right? You don't want to go back to work and infect your cardiac patients, et cetera. But it just didn't happen. And we tried to get CDC to give us the data. And they did say that that about 85% of people early on were negative, were not infectious at all. So they said the majority. So it was 85% was the number they gave, and 15% were. But again, we don't know the conditions there. But at least in the healthcare setting, people have we have the option to come back with without a test after a certain amount of time. After 10 days with a mask, and we've not seen any hospital nosocomial transmission. So I think that's the better way unless people really, as you said, are geared up for those rapid tests, and I would not worry about it.
So I also don't worry about it. I tell people don't even bother to test up to day 10, unless you're really worried and you live with immune compromised individuals or somebody you're really worried about. Who has so many tests anyway? And I agree with Bonnie and the studies in humans. No matter how many times you saw when you do a study showing that it's replication competent, I really don't know what that means. And I haven't seen a single study showing that that person after day 10 is still infecting another household member.
And these would be hard studies to do, obviously.
Right.
Well, so let's stick with Paxlovid just for another minute or so. A couple of questions. Does Paxlovid treatment reduce the risk of long-term COVID? And what about the duration course? Mike, you talked about when to start it, but one of the questions is, how do we decide on 5 days? And maybe longer is better, maybe 10 days is better. Is that being looked at now in clinical trials?
Yeah.
All right, go ahead, Bonnie.
Oh, yeah. So we understand. I mean, again, the data are not available for us, but the company, as you know, this was an old Merck drug that was repurposed by Pfizer. So Paxlovid originally took the nirmatrelvir and they repurposed it. And they just did a 5-day trial. I don't know how they came up with that study, but they are looking at longer duration. I don't see why that would be a problem, but it's not available under EUA. So we can't really do it unless you have approval. And some of us are trying to talk to the COVID-19 National Federal Task Force to see if we can do some larger studies, because it would be great to be able to look there. Now, the other problem, of course, is it's not available if you're not high risk or including age. And so it's a self-fulfilling prophecy this way. If you keep only testing in certain groups, you're not going to get it out any further. But the company showed very high top-line data looking at what they thought was a lack of non-inferiority, lack of a response in people with standard risk. That I guess that means no risk, or low risk. But there was an impact. It was small, there was an impact on duration of symptoms. And I do think that in the long run, this feels like oseltamivir. We get this all the time where people fight back and forth about, I don't want to give it to my patients. But at the same time, if it works, especially with a very transmissible agent where you're going to get millions of people, maybe it could have been moved forward, but the company chose not to. So I think we're kind of stuck.
So any quick response? By the way, Susan Cohn, who's a great friend again, is on the call and was wondering, Mike, going back to your point about starting Paxlovid right away or delaying a little bit. I think we've addressed that. But one of the other questions was Paxlovid and long-term COVID. I'm assuming we don't have solid data yet. Does anyone want to go out on a limb and?
I mean, there have been case reports of people with long COVID who took Paxlovid and they got better, but they haven't been controlled studies. And I think it's kind of interesting. Either you get it, it's probably a whole host of diseases, anyway, what we call long COVID. And maybe one of them is you have a viral reservoir still. And the other are more hyper dysregulated, immune system gone awry flavors. So it's hard to say, but at least, in the Division of Experimental Medicine at UCSF, they at least had an anecdote published 3 patients who responded to Paxlovid.
So I think we made maybe not a mistake, but I think the last dialogue we talked a lot about Paxlovid. We kind of gave monoclonals a quick pass, but there are other treatments and preventive approaches. You want to talk about this, Mike? You were talking in our prep about the situation at UAB. Do you want to summarize that a little bit?
So the supply of, I'm not going to pronounce it right, but bebtelovimab, which is the Lilly remaining monoclonal antibody, is becoming in short supply regionally. UAB is fortunate we've got a good number of doses, but that's the only one that works against the advanced Omicron variants, I think BA.2 or higher. So BA.4, 5 will not respond to the other Regeneron or the original Lilly, or for that matter, the GSK monoclonals. The Evusheld, the preventative one, still seems to have activity. So that's hopeful. So that the people that are on rituximab or other B-cell inhibitors, potent ones, that I think that's somebody who should be getting the Evusheld every 6 months. Their vaccine response is not going to be there for the most part, at least for their antibodies. And so I think that really is helpful. And the monoclonal that still works. It's a pain. It's a lot easier to call in a prescription. And now pharmacists can initiate the prescription locally. So takes the physician or PA provider out of the picture, which is probably in the long run a good thing. But I don't know what you guys think.
Yeah, I think that's correct. Talking about disparities, though, one of the things that we've heard from a lot of national societies is that we're not getting the word out to people who should be getting Evusheld. I think there are people who probably could benefit from Evusheld who just aren't either aware or their providers haven't given them the information. So it is important to get that out.
And I know, Peter, you deal with a lot of patients with severe immunodeficiency as a result of organ transplantation and other things in your practice. What's your take on this? And are you an advocate of this?
Oh yeah, definitely. I think monoclonal antibodies, long acting as a vaccine alternative, is really crucial for that early post-transplant period. If you didn't get the vaccines before, if you have multiple myeloma or something like that, like Colin Powell did, and people are just not getting enough. We have a lot of Evusheld still. I think I agree with Mike though about the bebtelovimab, which is the Lilly product, which we don't have a lot of, or it's dwindling. But part of it, I think, is because the government doesn't have enough money to buy stuff anymore. So I think the last time they bought 150,000 doses or something, and they're running out of money because that $10 billion is still held up in Congress. So I'm wondering if it's the shortage that we're going to see in drugs is just a harbinger for the future where they're shuttling money. They have limited dollars, this $10 billion held up. They're going to buy vaccines and probably minimize some of these other things. Maybe vaccines and Paxlovid might be the emphasis in the feds until they can get the money.
So that's actually happened. Now we were, a couple of my colleagues here, we were working to try to do a larger cohort study of high-risk individuals to try to get them access to Paxlovid and track them with EUA, with approval from the FDA, et cetera. And when we talked to the federal COVID experts, they said, they were hoping that we could get it done. And we're in the middle of trying to get this organized. And the reason it's important is they said, we can't do it because we don't have money. We don't have any more money to really put out messaging or PSAs around any of these antivirals. They're really focusing, as you said, they're channeling all the money down to vaccines at this point. I mean, I guess it's the better way to go, but that's why they're looking to societies to really try to get word out about these things. And it is important to get Congress to move on these dollars, because they're literally at the bottom of the barrel in terms of cash for implementation.
So one of the things I'm seeing in the Q&A is people really kind of taking us to task a little bit that we don't have a better definition of long COVID. That I don't think we need to go back to that today, but I do think that that's an area where we're going to need to see some better consensus.
So Paul, just to say, I mean, I think the others are involved as well, but we have hundreds of millions of dollars invested in these long COVID networks. I bet you a lot of people out there are part of the Recover networks. And I think we need to see some data. I mean, we've already started recruiting, a few thousand people, but we're 2.5 years in. The money just really was released at the end of 2021, but we really need to start seeing some data, pulling out case definitions. As we all remember, case definitions for HIV were critical for us to understand how to start treating people. And then to me, cancer, it's the only way you can really start assessing natural history and therapeutics.
Great. And so
I'll take the heat. But,
go ahead, Mike.
But go back to my other point. We've only been at this two years and 4 months. And if you look back to HIV, AIDS was first described more or less in June of 81. It wasn't until March of 83 that we even knew what caused it. And a test wasn't available till March of 85. So, I mean, we're early in this, and I appreciate the impatience, but I'd flip it around and say it's pretty darn remarkable that we've learned as much as we have in a short period. We just got to keep pushing.
Well, maybe I'm sorry, Paul. I think it's a good time to say this is a teachable moment for our federal institutions to see how we can be a little more nimble and still have good regulatory oversight. So it is a way for our federal agencies to really, I think, for example, the FDA has done a fabulous job. I see CDC did pretty well. I think NIH still has struggled more with their contracting and grant mechanisms just because of the nature of the way we do peer review, et cetera. So I don't think there's anything wrong with it, but I do think there may be some ways to fast track. It did take us a long time to figure out how to fast track HIV, but maybe we can learn from that for this pandemic and hopefully for the next pre-pandemic.
Well, certainly a topic that I'm sure we're going to come back to as these dialogues continue. I want to, Bonnie, we talked last time about pediatric vaccines, and it was kind of a mess at the time. There were still a lot of decisions. Are things any clearer now? And tell us a little bit about what you're speculating about the rollout of the infant vaccination and who's getting it and who doesn't want it.
Well, the good news is we have vaccines now for everybody 6 months and older, and that's what we recommend for everybody for flu, right? So everybody 6 months and older should get flu vaccines. Everyone 6 months and older should get COVID vaccines. We now have 2 vaccines. So Pfizer and Moderna both have vaccines for kids under 6. And there's also now two vaccines for a choice of vaccines for kids who are older kids. The problem is implementation right now is very messy, and I don't want to go into too much detail here, but the problem, of course, is, it's new, as Mike said, we're just getting into it. Supply chain issues came up. So now Moderna is really trying to push out the vaccine vials that they have. Some of the vials are not labeled for children. They're the booster doses for adults. So because it's the same dose. So in a practice where you're seeing a lot of kids, you know, you have to be really careful about looking at the labels, because the labels there's, you know, different dosages for even for an individual product. You have 3 different doses depending on how old the child is. And so at this point, everybody in the American Academy of Pediatrics world has little laminated sheets so that you know what color cap you have and what color, and some of them have 1 color cap and a different color label. So it's messy. Now, the only other thing I want to say is, here's the problem, is that the doses that were shipped out, the 10 million doses or 5 million that we were going to get for June and July, were already sent out before all of the labeling changed. So those are all out. And if people didn't order them before the approval came, then you're out of getting Moderna. A lot of people are right now then just using Pfizer. And then the other issue is that there aren't any billing codes even available yet for the Moderna product. So even if you want to use it, you're not going to be able to bill for it. So right now, what I'm hearing from pediatricians, forget what the public is saying, as we know there's a lot there, but the pediatricians are just defaulting to Pfizer.
Right.
Yeah.
Got it. So I mentioned as we started this that another infection that's gotten a lot of news lately is monkeypox. Just for the audience, the panelists have a call before these dialogues to kind of review where we think things are and to raise questions that we want to make sure we address. We wanted to make sure that we didn't spend kind of all the time talking about monkeypox as we probably could, but it has been a big story, and one that's clearly evolving quickly. So I'd like to spend a few minutes. I hope we can still get back to some COVID questions from the audience, but Peter has been kind of increasingly one of the national kind of spokespersons on monkeypox. You want to tell us a little bit about your experience and where we stand, both of the clinical condition, the transmission, and the treatment, all in a few minutes?
Yeah, so definitely scope of problem first. More than 7,000 cases around the world. California and New York leading the country, 136 California, 131 New York. Doubling in the last week in the Bay Area, as an example. So a lot of disease now, probably the tip of the iceberg, limited by not a kind of clunky diagnostic system in the beginning. Had to fill out lots of paperwork to get a PCR test, either from the state or the CDC. Now liberalized to commercial labs like LabCorp yesterday. So I think hopefully it'll be better. And the reason why that's important is because, like with COVID, if you don't know you have it, then you can't take precautions and not transmit it to other people. So I think lots of people I'm seeing now have gotten it not from a known contact. There are some people certainly who have. So that's diagnostics. In terms of vaccines, we have a decent vaccine, Jynneos, but not enough of it. It's much better than the ACAM live replication competent vaccine. This one is not replication competent, very safe, but released only in spurts. So 56,000 the first shipment from the feds, then 300,000 expected within the next few weeks, and then put in an order. There's only one company that makes it. It's in Denmark. They were like remodeling, so they're put on hold, and hopefully some millions by the end of the year. So vaccines are great for monkeypox in general, because unlike COVID, the incubation period is longer, so you can have an effect on disease outcomes by preventing the disease by actually vaccinating contacts. So that has been the focus of much of public health, is trying to get the contacts. But again, because of the diagnostic issues, that's falling a little bit short. New York has started vaccinating everyone who wants it, but they've run out of, like, it goes on Zoom, on Google or whatever appointments, and like they go out and it's harder to get an appointment than French laundry on the first of the month. It's really, really tough in New York right now.
And that's not a laundry service.
Yeah. I know people have refreshing
right.
to get those appointments. And then therapeutics is really interesting. We don't have a short supply of therapeutics. I was talking to the DPH in our local area yesterday, and they were saying, so far California says they have enough. We treat people who have severe disease. So kids under 8, people who have disease in their mouth or in their rectal area, or who are immune compromised, or pregnant persons, and certainly people who are hospitalized. It's called TPOXX. It's kind of a cool name, tecovirimat. It stops the envelope being produced in the virus, so it doesn't infect other cells. And I've seen, I mean, in my small end, I've seen miracles. I started 2 patients on Monday, 4th of July, and they've been sending me pictures every day, and they've been clearing off so dramatically.
So tell us what, those of us that haven't seen a case, what does it look like? How do people come to your attention? And how do you, what do you mean by responding? How do you know the response?
Yeah, so everybody gets a rash at some point. So in the studies, there was a nice study that Carlos had shared with us in the Lancet Infectious Diseases, and is posted. Everybody gets a rash, but not everybody gets a prodrome in this particular outbreak. So the prodrome is fevers, fatigue, lymphadenopathy. That can happen in like 75% of people. That happens about anywhere from 7 days to 2 weeks after the exposure. And this study was median of 4 days, which seemed really quick for monkeypox in textbooks. And then you get the hallmark rash. So in this particular outbreak, it's starting off in the genital area, which is very different from the textbooks. Again, either in the penis, the anal area, people can't see it. They can be confluent, and they can have a lot of rectal bleeding, rectal pain, proctitis, superinfections. Also, interestingly, 25% of people are presenting with another sexually transmitted infection.
Right.
So it's really important to screen people for everything, which I'm sure this audience is doing. In my own experience on Monday, one of the patients of the 2 I treated also had another STI. So in both the cases, of course, they were serious, so we treated them. They both had rectal confluent lesions, had rectal bleeding, really, really painful. And then it spread from the genital area to the face and trunk, arms, palms on either side, and feet, soles of the feet. So when I say responding, in the patients, they reported, the rectal lesions shrinking a little bit. It's still there, still some discharge, maybe changing from bloody to, one of them described it as Mountain Dew to me today. And then in the other, like, really super dramatic case, the patient had extensive lesions all over his body, including his face, very painful. And now his face is cleared up. And Bonnie had mentioned in our pre-call that it actually looks very much like hand, foot, and mouth disease. So that when the dermatologist sees it, sometimes they think it's, one of those variants. So they're very clearing a lot.
So one thing I just wanted to mention about hand, foot, and mouth is there aren't very many rash illnesses, especially blister or raised lesions that present on the palms and soles.
I was going to say, when I was in med school, syphilis was it, right?
Syphilis, gonorrhea, Rocky Mountain spotted fever, but the pox viruses can do that, and hand, foot, and mouth can sometimes present that way. So, it is summer, so you're going to see some enteroviruses circulating. Unfortunately, there's not a lot of it. But the other thing I wanted to mention, because Peter talked about the textbook, is there's very good data now to show that these strains are quite distinct from the ancestral monkeypox strain. So, the traditional monkeypox has them for case fatality rate of about 6 to 10%. So we're not seeing that here. I think there's been 1 death reported. So I do think this strain is a very distinct strain. It really started in a particular social network super spreader event. So we think that will be the ancestral strain for this outbreak.
So and that's a comment from one of our participants. More infectious, but you're saying maybe less virulent, and if virulence is defined as causing clinical disease. So why would a spreader event lead to a change in the virus?
That has to do with the mode of transmission, probably. I mean, if you're talking about high numbers of very close contacts in a very short period of time, and then people coming together in one location from many different places and then going back home. I think if you trace it back, that's probably the likely way that this disseminated so rapidly. And I think the long incubation period made a big difference too. I mean, relatively long. So I think that's the issue here. The other problem with, normally, I mean, if all of you who remember, I mean, I am old enough to have a smallpox scar on my hand.
Yeah, that's one of the questions that I'm seeing in the Q&A.
Yeah.
What about those that had smallpox?
So there is evidence of some immunity. So I don't know that we actually have data on people who were vaccinated. The last vaccines were given, by the way, in 1977. Fun fact there. So if you're, count backwards, if you weren't born then, you don't have immunity unless you were in the military and may have done
my scar from.
Yeah, so there is evidence of neutralizing antibody. So you might be protected. I would still be careful, obviously, but that's a very different demographic relative to the risk groups that we're seeing now.
So Mike, you watch out for the World Games there in
Yeah,
Birmingham.
that's right. I think one other quick tidbit, the last outbreak, at least in the United States, seemed to be around 2003 from imported animals.
The large African rats.
Yeah, and that was it, and that was a different strain. And I was going to make a bad joke and say, have we seen T-pox rebound yet? But maybe it's too soon.
but Mike, that's a great point, because it shows you that I think with that outbreak in 2003, that was somebody brought in an exotic pet. It was a large African rat, and it infected local prairie dogs. And then people had pet prairie dogs as well. And the reason that one was contained is, again, mode of transmission. People don't really have very, very close contact with their prairie dogs. And so they were able to ring around the prairie dogs. And that wound up with about 45 cases or so altogether. But they went through the veterinary route. Here, the problem with these areas is trying to go to locations where people gather. If you have thousands of people gathering, how do you vaccinate those groups?
Yeah, so case contact finding with these are probably impossible given the nature of the transmission. So a quick question, monkeypox vaccine to people with HIV with low CD4 cells, safe or not safe? Live vaccine?
I would not give ACAM, the old vaccine. So here's the other issue about supply chain. So ACAM was the traditional vaccine that we had for smallpox, and it works against all the orthopox viruses. So this is monkeypox as well. We have 100 million doses of that vaccine, and it works very well. But if you're immunocompromised or you have eczema, you have to be really careful. And there's a pretty decent risk of myocarditis also, even if you're not immunocompromised. So it's not a great vaccine in terms of safety for a otherwise healthy person. But remember, smallpox was pretty devastating. So the new vaccine, the Jynneos vaccine, the total supply that the company has is somewhere on the order of 5 million doses. No, sorry, 7.8 million doses.
That would be safe though for HIV.
Oh yeah, it's safe. It's a non-replicating, it's a replication incompetent live virus. So it's very safe and effective. It was approved by ACIP. When did we approve it? I think it was like 2 years ago. Nobody paid attention because it was a backup for smallpox, but now we have it, which is great. But the company won't, 8 million doses for the world. I'm not quite sure what that's going to do.
So we just have a couple minutes left. And one of the participants says, Peter, could you quickly go over the testing procedure? What's the diagnosis for monkeypox? Is it a swab culture?
It's a flex swab, and it goes, right now they liberalize it to any universal viral transport media. Before it was kind of like a clunky, you have to find the right tube, but just like tons of people have those universal viral containers in multiple clinics and labs. It's it's the most common one. So you just send it, and you can send it to LabCorp now. I think the CDC would still like a backup sample to do confirmatory testing. But the important thing for people to know is that if somebody has severe presenting disease and you have a high likely suspicion for monkeypox, that they could be eligible for treatment even before the confirmed diagnosis, which can take 3 or 4 days. So the DPH has allowed us to treat these people because they still want to know if you're treating somebody even before the final diagnosis. And in the cases I've treated, the final diagnosis did come back as positive.
And how well is the CDC tracking monkeypox? Is there a good reporting?
Yeah, they're actually, well, again, it all depends on local reporting, but they're actually updating their case rates at the global level on a daily basis right now. So if you go to just Google CDC, well, you can go to CDC, the CDC website and look under disease conditions under monkeypox. And they're updated every single day in the afternoon, close of business on the East Coast. So you can get a real-time count of what's going on in the country and the world, actually.
So really want to thank the panelists for participating in this again. It's great having you, and I know that the audience really appreciates this. There's still so much going on. I mean, just today, I think we've touched on a number of topics that are still very much in flux, both with COVID and with monkeypox. I think hopefully when we meet again, we can get some more clarity on the vaccine. We can learn a little bit more about the Paxlovid rebound, and for those people that are really kind of chomping at the bit, we'll work on getting a case definition of long COVID. It is frustrating, and we do need it. But thanks to everyone for participating. Thanks for the IAS-USA for putting this together. Donna Jacobson.
And thanks to Paul. He's such a great moderator. Thank you for managing this.
So the person that I keep forgetting to mention by name is Jose Francisco, who is a really great staff person with IAS-USA. And I want to thank him as well. So stay tuned. And here on the slide now are some other ways to get information about what the organization is doing. So thanks again for everyone. Talk to you soon.